Good afternoon, everyone. Assalamu alaikum. We aimed in this study to revisit some parameters or few parameters that either usually or routinely have been measured invasively in the catheter, for instance, the ventricular arterial coupling. So we were testing whether to do it non-invasively using MRI, or we have aimed to revisit two parameters that have been discussed previously in other pathologies, including HCM, but not in HOCM, and we tried to compare them to the routinely used indices. For example, the ejection fraction, as you may all know, is being used as the parameter for follow-up of HOCM patients, whether before or after the myectomy or interventions. We aimed to test those parameters in patients who had myectomy. We didn't discuss any patients who had atrial septal ablation or, alcohol septal ablation in HOCMs. We successfully recruited 79 patients who had hypertrophic cardiomyopathy with significant obstruction that required intervention, required the myectomy. All the patients had the vital signs, MRI, echo on the same day before the surgery and after the surgery. We also successfully recruited 15 HCM cases who did not show any obstruction in the LVOT in order to compare the parameters before, after myectomy to this group of patients HCM and how significantly they will change. The sequences that we used were the routine, usually methods and cardiac MRI, 2-chamber, 3-chamber. The short axis was measured to measure the myocardial mass, ejection fraction. We used the 2D flow aorta to measure the stroke volume above the aortic valve. But we have adjusted some, or we have added some parameters to measure during those scans in order to calculate the elastance of the aorta and the elastance inside the ventricle in order to calculate the ventricular arterial coupling, which is the change of the pressure for a given change of a volume. So if we discuss that, we measured the end systolic pressure in the arteries using the brachial artery pressure and the pressure inside the ventricle, which is the same as the aorta pressure or the arterial blood pressure, in addition to the obstruction or the gradient exerted by the outflow tract obstruction. The relationship between the elastance in the aorta divided by the elastance in the ventricle will reflect the interaction between the aorta and the ventricle. In simple words, if there is a small preload coming through the mitral inflow to the left ventricle, there is a small pressure inside the left ventricle, there is a small stroke volume, which means a small arterial pressure. And the other way around, if there is hypertension in the aorta, this will be reflected in reducing the elastance inside the ventricle. This is what the ventricular arterial coupling would reflect, this interaction before and after surgery. In addition, the ejection fraction is the measurement of the stroke volume divided by the end diastolic volume. So it discusses only the changes in the volume, but it does not discuss or reflect how much of the myocardium exerted or contributed in order to offer this stroke volume. So applying the same stroke volume divided by the LV mass would tell us how much of this myocardium have been used in order to contribute for this stroke volume. If we say 100 milliliter is the stroke volume and the myocardial mass is 200 gram, this means that 50% only of the muscle is contributing in this stroke volume. Applying the changes in the volume, merging the changes of the volume and the myocardial muscle, this would reflect the changes in the entire ventricle, so the changes of the global function of this ventricle. The results have showed regarding the ventricular arterial coupling that has changed significantly. So pre-operatively 0.3, post-operatively 0.6, And in the normal range, in a normal subject at rest is 0.7 to 1. So it's almost approaching the normal values. And comparing this to the ejection fraction. So the ejection fraction, as you may know, that before the surgery, there is the supernormal ejection fraction in Hawkins, sometimes up to 90%, 80%. But what is the goal of the surgery? Is it to reduce it down to 50? Is it to reduce it down to 60? Is it to reduce it down to 70? We don't know, right? But the ventricular arterial coupling, in order to get the interaction, this reflects the performance. So the goal would be to as normal as possible. The same applies for the global function index, and the myocardial contraction indices were different and significantly different before surgery from after the surgery. Again, ejection fraction reflects the changes in the volume, but it does not reflect what is the interaction between the ventricle and the artery. It does not reflect how much of this myocardium has contributed in order to reflect the stroke volume. The parameters are feasible, could be measured non-invasively, yes, but I think long-term studies, further studies are required to compare what is the clinical impact on those patients. If we starting replacing the ejection fraction with those parameters, are they predictors? Are they well enough established to follow up the patients using those parameters rather than the routinely used indices? I have nothing to disclose, and thank you.
Thank you, Dr. KHARABISH, for this very nice presentation. And our next speaker,